All right, I think we'll kick off. It is 8 o'clock, or my time, 8 o'clock. So I'll kick off. So, good evening, everyone. Welcome. I'm Kathy Stalley. I'm General Manager of Duchenne Australia, and I'm also a mum of 6-year-old George, who lives with Duchenne. Like many of you here tonight, this work is both obviously extremely professional and deeply personal for me. On behalf of Duchenne Australia, thank you for joining us for our first session of our 4-part webinar series, Behaviour in Duchenne. Duchenne Australia is a parent-led national charity focused on improving quality of life, access to care and therapies, mental health support, advocacy, and long-term outcomes for Australians living with Duchenne. One of the constant themes we hear from families is this: we understand the physical side of Duchenne, but nothing truly prepares you for the emotional and behavioural challenges that come with the condition. Because Duchenne affects more than muscles, it impacts cognition, energy levels, sleep, anxiety, and overall capacity. And when behaviour changes or becomes challenging, it can feel confusing, confronting, and at times extremely isolating. So that is exactly why we co-created this series. Tonight, I'm very pleased to introduce the team from Duchenne Muscular Dystrophy Therapeutic and Behavioural Consulting. Michelle is a developmental educator and behavioural practitioner who's been working within the Duchenne community since 2010. She provides therapy, behaviour support, assessment and family training, specialising specifically in Duchenne. She's also a mother of Jack, who lives with Duchenne, bringing both professional expertise and lived experience. Thomas is a developmental educator, teacher and behavioural practitioner with experience in therapy and special education, with a strong interest in supporting children with neuromuscular conditions to participate meaningfully at school and in their communities. Together, they bring deep practical experience grounded in real-world experience. Grounded in real-world experience. On a personal note, DMD Consulting supported our family last year when George started kindergarten, and we faced some behavioural challenges ourselves. The kind I'm sure many of you have experienced. We actually had George's OT meet with Michelle, and her insight into his behaviour without even meeting him was astonishing. It shifted the way we understood what was happening and how we responded as parents. So that perspective is obviously incredibly powerful. Tonight's session is the first of 4. We'll explore what Duchenne is, how it progresses, how fatigue impacts behaviour, and how reframing behaviour as communication changes the way we respond. There'll be time for Q&A throughout, so just pop your questions into the chat as we go. And this session is being recorded and will be shared afterwards. And you'll also receive a short survey. We genuinely value your feedback as we continue building programs that truly meet families' needs. We're really glad you're here. These conversations matter, and understanding behaviour in Duchenne is a critical part of supporting our children well. So I'll hand over to the team.
Thank you.
Hello, welcome everybody.
We're just going to share the screen. Cool. Kathy, let us know if there's any difficulty with the screen share, but it should be all good.
All good. Well done.
Yeah, awesome. I'm just going to make that. Welcome to the first of the 4 webinars. This one, as Kathy's already introduced, is a bit more of an introduction around DMD, the progression, fatigue, and reframing behaviour as communication. So we'll jump straight in. This way. There we go. We just firstly want to acknowledge the traditional custodians of the land we are presenting from, which is the Kaurna people of the Adelaide Plains, and pay our respects to the elders past, present and emerging, and also acknowledge the custodians of the lands on which each of you guys are joining, because I know there's a lot of people from a lot of different states. So thank you. Welcome. Yeah. Kathy's very kindly covered pretty much all of this for us, so we won't spend too much longer on this, but yeah, I'm primarily a DE, but also currently registered as a teacher and behaviour practitioner. Have been working here almost 4 years, about 3.5 years fully qualified, and about 2 years before that as a therapy assistant. Background in special education, so a lot of experience working alongside schools, and a lot of that work is around, supporting them in understanding behaviour and on school site. Yeah, Michelle. Yeah.
And I've been around the community since around 2010. And about 6 years ago, I decided that I wanted to focus all my energy and time onto kids with Duchenne, with behaviours of concern, and I think the kids that we work with are a bit of a niche within Duchenne. And yeah, I've been doing that for a while now and love it.
And with the agenda, we'll probably, it does follow this, but we'll want it to be a bit more flexible. So we'll do a bit of a background on what DMD is. I know that's probably what a lot of you guys will know already, so we won't spend too long, but it's definitely worth looking, I guess, as a foundation, and around what dystrophin means. Then we'll look beyond the physical, so how it affects more than just the muscles, and what progression can look like, which will, I guess, lead us into understanding around fear, fatigue, anxiety, motivation, and reframing that behavior as communication. Looking at some of those common behaviors that we do see. This is a bit more of the what, I guess, and then the next webinar is more of the why. But I think it will just be equally as valuable to cover. So,
and some of the stuff we cover, some of you will know it, others may not. Yeah. But I think it's still good to do a bit of a recap.
Yeah. So I guess, what is Duchenne, and what do we know it to be? So it's a genetic condition which affects how the body builds and protects the muscles. We say it's the most common genetic disorder diagnosed, and we know there's around 30 different types of muscular dystrophy. Usually is noticeable in early childhood. Typically, we see diagnosis as around the age of 4 to 5, but that can obviously vary. Many cases are genetically inherited, approximately 30 to 33%. As a result of a spontaneous mutation. What we see in the research is that it's affecting around 1 in every 5,000 live male births. Sometimes the numbers vary, and it might say 1 in 3,500, but based on what we go off of, that's the current numbers. Yeah. We know it causes progressive muscle weakness, but it is more than just a physical condition. It impacts fatigue, learning, emotions, behavior, daily functioning, all of those areas. When we look at the why, that's in that second webinar. That's really where we'll sort of unpack how does it impact those areas. But today we'll be mostly looking at the what, the presentation of it. And while there is currently no cure, we do see that advances in care mean that many young people are living a lot longer, and they are living into adulthood. And we do need to be preparing them for that transition, and setting them up for meaningful experiences and success.
Yep. Should I do this one?
Yeah.
All right. So some of us are carriers and some mothers aren't carriers. Generally, it goes through the X chromosome. So I'm a carrier. I have a good X chromosome. I have a cruddy X chromosome. And when I passed one of my X's over to my son Jack, he picked up my cruddy X chromosome and he has a Y. So in me, I am a carrier. I do have things like cardiomyopathy and large calves. But if to look at me, you wouldn't think I was affected by Duchenne. For my son, who's got a Y and a cruddy X, he displays the symptoms of the DMD. So that's the way it's passed through females, why females tend to be carriers, and the boys show the symptoms.
So you'll often hear us refer to boys as we go throughout, but we do recognise that there are instances where we're talking about girls who may have what's called dystrophinopathies, or even young people who have Becker muscular dystrophy. So, if we do sort of say boys and not individuals, that would be why. But we'd like to just cover that.
And I think we are noticing a lot more what we would call manifesting carriers, where we do see the effects of the missing dystrophin in them, sometimes in behaviour.
I guess it's worth thinking about what the DMD gene is. So the DMD gene provides instructions for making a protein called dystrophin. Duchenne, or Becker in this case, is caused by a change or a mutation within that gene, which means the body can no longer make dystrophin properly. If it's a diagnosis of DMD, it's around if it's impacting the reading frame. So we'll cover a lot of that in the second webinar series and really get into the nitty-gritty of mutations and how those impact presentation and behavior. But it's made up of 79 exons. So an exon is basically just a region that codes for dystrophin across the body, and a mutation can happen anywhere along that gene. So it's the largest gene in the body. All of those 79 exons work together. So wherever that mutation site is and the type of mutation can have real impacts on the presentation of the disability and the everything about it. So yeah, cool. So what is dystrophin? I think often people will refer to it as the banana skin analogy, which you described quite well, but it's a bit like a shock absorber. So it links the inside of the muscle cell to the surrounding support structure, helps the fibers stay stable when they contract and relax. So if you're thinking about it as the banana skin, the muscle cell's the banana and the dystrophin is the skin that holds it all together and protects it. Without it, the muscle cells are more fragile, get damaged more easily, and will weaken over time.
I like the banana over the posh medical one.
So development, would you like to start with that?
Sure. So I guess we work with a number of kids, and from the data that we've got, many of our kids, some were diagnosed early at 2, and we had a bit of a spout here where we had about 3 kids that were diagnosed at 7 or 8. So, diagnosis can come at any time, really. However, research says between 2 to 5. Then we find that the kids hit this plateau stage at around 6 to 7. So for some children, that's when they might start taking steroid treatment. But basically, the plateau stage is, I guess, they've reached their maximum, their peak of their physical ability, and that's where we start to see it kind of stagnating and not building up any more muscle mass. By 10 to 12, we see some of the kids needing some equipment. Some have powered mobility scooters. Others may just have manual wheelchairs. And some may very quickly move into powered mobility, as in full powered wheelchairs. However, they may still get in and out of that chair.
You might also start to see the introduction of other forms of equipment or within different areas of life. So, a cough assist machine, maybe trial, BiPAP machine, things like that can occur at that age.
Yeah, conversations might start to occur about needing those things depending on your respiratory appointments. And then often we see around the age of 14, most of our boys have powered mobility, e.g. a powered wheelchair. However, we do know that in other states there are other kids who are still weight bearing and they're 18. So it really does vary. But from the kids that we see, a lot of them, by the time they're 14, have some sort of powered mobility in their lives.
And there's often a lot of plans will be put in place around then too. So transfer and care position plans, or eating, drinking care plans, frequent reviews. So you'll have a good team around you at that stage. And then, moving into adult care, which is 18 plus. We also do like to reinforce, we will describe development in stages, but it is important to remember that it does look different for every child, every individual. When we are talking about these stages, that's what the research shows and what we see in our cohort, but it doesn't necessarily mean that that's what it means for your child at this stage. Again, so looking at development, you might want to talk more around these stages.
Yep. So we've got the Superman picture. I think Jack would have been around 4 or 5 in that picture. And then moving on to the hat picture, I reckon he would have been about 7 or 8. No, maybe a bit younger, 6 to 7, and then getting up more into 10 to sort of 13, and then teenager, 15. And the very last one, he's just coming up for 20. So it's kind of good to see. I think these kids, when they're little, are so skinny and scrawny, and then they go through these bigger, sort of chubbier times where the steroids often kick in, and then they'll slim back down again as they get a bit older. And, I think that there's a lot of there's medication side effects, but there's also the fact that a lot of their muscle mass is turning to fibrosis. So, some of this stuff isn't always controllable. But yeah, there are Jack pictures.
I think when we look at the stages of development, one of the key ones we focus on is that plateau stage. And again, it does occur at a different time for every individual, and it is hard to predict and hard to know when it's coming up. And it doesn't mention it here, but I think that sort of lends to the importance of having a good team around you and having assessments and working with the physio, because often what we will see is when the physical progression does start to decline and the North Star shows those decreases, we will almost always see an increase in behaviours. And what we're noticing is that it's usually when that fear starts to creep in. So a lot of the young people will have those thoughts in their head around, am I going to fall? Can I keep up? It might be during PE at school or at physical activities at school that they're finding harder to do, and having those thoughts of what if they can't do it anymore, or if people will notice. I think that lends to equipment as well. So
I think this is the time when we start to see the kids. So very often in South Australia, we don't see the children until they get to that kind of 5, 6 years old, sometimes kindy, but they're going through that plateau stage. So their bodies are starting to ease off a little bit. But demand is starting to increase. They're going into new environments, they're having to coordinate themselves better, but they're also exposed to peers. So they're kind of saying, well, hold on a minute, why is this happening? What's happening? Why can't I keep up? I'm going to sneeze. Me. What if I do fall? Why can't I climb that as well as that kid? So, around that kind of plateau stage, we definitely have more people reaching out to us. And often we'll go straight to physio and say, can you give us a copy of the North Star? Can we get the baseline? So the North Star is the physical measure for these guys. That's the gold standard for the assessment. And as they get older, it's an EK test. But regardless, we would always look at those physical elements and keep an eye on them, because as we see physical decline, we almost always see an escalation in behaviour.
Yeah. And I think it can be tricky times too, because like Michelle said, there's a lot of other changes going on. It might be starting school or, moving between classes. And often what we will see is that it presents as escalating behavior. And, I don't like the term being naughty, but that's often what, old school teachers or other individuals may see it as or may label it as. And it's usually just a misunderstanding around Duchenne, because usually what we're seeing is it's actually that fear of losing ability or control. And it's quite common. I think a lot of families will come and share these experiences.
The word defiant.
Yeah.
They're defiant. They're not, and it's like, well, let's just break this down a little bit to why they're being defiant. And perhaps we can start, over the next 4, we'll unpack this more.
Yeah.
But
and I think, commonly what we do see and what's sort of reflected back is around refusal or avoidance. So saying no or pulling away from tasks and, things that maybe even they once did a couple of weeks ago, now they're saying no to, becoming quite direct or blunt and, presenting as if they have that reduced social filter, or speaking quite abruptly or rudely to people helping or supporting them. We see a lot of repetition and, becoming stuck on thoughts and topics, or even just needing ongoing reassurance, or just consistently sort of seeking responses to things they may have been told already.
They may even lash out at the kids. They could be pulling on other kids or hitting on other kids, or, those types of behaviours too.
Yeah. Heightened emotional reactions. Often you might see them become upset quite quickly. And we do look at, again, in the second webinar and forward, we'll start to explore, I guess, other than the progression and that fear of it, what are the underlying factors that influence these presentations, and in the sense of the disruption of the dystrophin in the brain. But it's really important at this stage, because often that progression is a catalyst for the escalation, and increased rigidity or control, and needing things being done a certain way, in play, in work, however it may look. We can see that happening quite.
And I think as well for play, we take for granted that children know how to play, and this is a skill set that you build in those kinder years. So if you haven't had the opportunity to build them into those kinder years and you start to go into school, then sometimes kids do what they need to do to get their need met within play, and sometimes that can look very different to the other kids, and because of that skill set being not as well established as their peers.
Yeah. And I think that has real impacts then as they go through the later years of schooling or life, because play does start to look very different and interests change, and they can blend on interests that are entirely different to their peers, or play can become more complex, not just physically, but in terms of the cognitive skills needed. So it's I think a big factor that needs to be focused on is supporting those social interactions at a young age. Yeah. So I think then what we see is that link between fear and parent grief, because around that plateau stage, fear increases not just for the individuals but parents as well, and that grief will have a real impact. And I think I can't speak to it from a personal standpoint, but from what I know, there's a strong urge to, keep them on their feet and maintain independence and really encourage them to push through and stay as independent as long as possible. But what we see and what we know for the young person, that they're experiencing that fear of falling or not keeping up, a lot of uncertainty. It might not be talked about because these conversations are hard to have. And there's that increase in fatigue then too. And they often might not have the skills to verbalize that, they might not share that with their families or their mums or dads or anybody.
I think, that when that, I think every parent dreads that electric wheelchair. It's like, oh, this is awful. It's awful to see. And we should have, maybe we'll find this video, because I've got a video of the day that we got Jack's powered mobility, and he's in the back garden and he's chasing the dog with learner plates on, and he's yelling at the top of his voice, and the dog's running around like a Fruit Loop, and Jack's chasing the dog, and it's all very exciting. And for a moment, I just stopped and went, actually, it's me that's struggling with this, not him. And so, I think that what we see is that when the kids do shift into powered mobility, there's a sense of independence and the ability to go where they want to be and keeping up, that as parents, I don't think we feel that so much. We look at it and it's just like, you just want to go in the toilet and lock the door and cry, because it's like something's being taken away. But in actual fact, something's being given. And I think whenever you work with your physios and your OTs, it's all about continuously trying to put in so that they maintain their independence for as long as possible. But it's very hard for parents to watch.
And what we do often see, which we will talk about further down the track, especially in the fourth webinar, is that there's a lot of overlap with introducing new things in behaviour, and it's not always as simple as just sort of putting it in place and hoping for the best. There's a lot of lead up and a lot of work, and I think those early years we spend a lot of time planting seeds, and it can be, I guess, scary for parents too to think, well, what are we going to say? What will you talk about? What will you address? And it's not necessarily you talk about what they need to know right then and now. But I guess, sorry, were you gonna?
I was going to say, lots of people, when I first went into doing this as a business, people would say to me, what are you going to talk to my child about? And I say, well, we're not going to talk about the end result. What we're going to talk about is where we're at today. What are our legs feeling like? Where are we at? How do we feel? What's tricky at the moment? They're the things that we're going to address. And I think one of the hardest things about the DMD journey is learning to be in the moment and not too far ahead of yourself. And that's a really tricky thing to do, I think.
So I guess, one of the key takeaways, thinking back to the behaviour, is that when we do see that escalation, it's often a sign that they are struggling. It might not just be they're resisting and not wanting to engage or not wanting to do these things. It's a sign that they're struggling. And I think, being mindful of your own experience as parents or guardians or family members or professionals, whoever's here, and the child or the individuals is the first step to supporting them. Falls, breaks, and fractures we do like to touch on, because they are, a real.
You've got to love that femur. It's gonna go. I don't know any boys that are older that haven't done their femurs. It's a little bit scary.
Yeah, so it does happen. It can happen. But getting back to independence, and we say independence because that can look different to any individual, and it could be getting back to autonomy, but it is a whole team approach. It's often led by a physio, but you have a team that will wrap around you and work with you through that. And you can see the pictures there. Jack had a lovely one.
I think that there's in recent years, working with the physios and the hospital, we've had sit to stand wheelchairs come in, and the kids are standing a lot more in their chairs. And I think one of the things that's really come to the surface with this is really being mindful of bone density. So I would really be checking bone density before using a sit to stand, because for my son Jack, he actually was 19 when he did his femur. He wasn't weight bearing. It was an accidental fall that led to the femur break. Then he had a double Achilles release. So he had almost 6 months with no standing and not in the hydro pool. And by the end of it, we we saw endocrine and they were like, yeah, his bone density is so low that if you actually use his sit to stand, he will probably snap another bone. So I think it's really being really conscious to use your teams and make sure that if there's periods of time where your kids aren't in the pool, or, you know, their bone density may reduce, and they will reduce regardless, because as we go on to our next slide, we'll talk about steroids. But I think it's worth being mindful that, you know, if you feel like your child isn't having, they may also have bone thickeners each year, which are amazing. But I would just be mindful and definitely talk to your physio and your hospitals and be mindful of bone density.
And I would imagine this also links back to that fear as a parent, and you might be able to comment more on it, but, you know, not really wanting to know, or sort of that head in the sand, it's just another thing to do or to hear about. But really, I think when you look at the outcomes, it's actually a positive, and it will really set you up to.
Well, knowing, if you know that there's low bone density, there's things you can do, like have bone infusions and take vitamin D, and, you know, so I think it's around having the knowledge to be able to still work on those things and build those things up.
Like Michelle mentioned, steroid treatment. So when we do talk about progression, you know, it isn't just the body that changes. There's new treatments, new routines, new expectations. Starting steroid treatment is one of those. We know the benefits that we see. There's that, you know, increase in muscle strength, motor skill ability. You might prolong that ambulation and have those reduced incidences of scoliosis. Side effects are real. They are there. Increased vulnerability to fatigue. We often hear about it creating challenges in behavior and difficulties in behaviors, but that's most of the time not the case. It's more just magnifying what might have already been there. Like Michelle mentioned, the decalcification of the bones become more brittle. The cushingoid, you'll see the puffy cheeks, you know, the weight changes, things as such, and delayed puberty and adrenal suppression. Is that something you want to comment on more about?
I think in terms of, I don't know if who has the emergency cards. We do have one on.
They're not on these slides, but
yeah. So I think it's there for new families. There are emergency cards. I don't know whether you guys.
I'll jump in. We are creating emergency cards with most up-to-date protocols. So watch this space. But yes, it is very important for everyone to be aware of the adrenal suppression piece.
And also making sure your schools know about them. Yeah. That's really important.
From the school's perspective, it can be quite scary for them when they get told about emergency care or cards, and they see the cards and they think they have to know every fact on there. And often it's just knowing what the protocol is, which is someone has it at the front office, or the teacher has it, or it's in the young person's bag, knowing to give it to an ambulance.
In the country recently, physio Kerry, who we work really closely with, we were up in the country, and one of our country kids had slipped on some gum nuts and it ended up on his back. And the teachers were ready to get him up. No, leave him, where are you? Don't try and move him. Let's just see. We got him comfortable. We called the ambos and we brought out his emergency card that was all the way at the office. So one of us went down to get it, brought it up to the paramedics, and they were very thankful for the fact that we'd given it to the paramedics. So, you know, that we don't have to over-respond, but as long as schools know to get it to a paramedic, that's all they need. What else was I going to say about steroids? So years ago, when kids were on steroids,
all the way back,
so pre-steroids for some of these kids years ago, often the scoliosis would become really quite significant, and sometimes they would have to go through rod surgery, where they would put a rod in their back and fuse them to all their vertebra, which you can imagine is highly invasive, and, you know, not everybody recovered well from it. Since steroid treatment has been on board, very little kids have that operation anymore, and I really feel like having the kids up straight and on their feet longer is putting less pressure on their internal organs, and so again we're getting longevity. So it's not for everyone, it's a family choice, and I think that's also something that should be acknowledged, that, you know, steroid treatment, we were on it for a while, and I just couldn't cope with the magnifying behaviours as Jack got older, and it was our choice to come off. So I do think that, steroid is a very personal choice for each family, and yeah, people need to navigate that the best they feel.
I guess thinking back to fear around falling. So, even if a young person still is on their feet, they may be feeling scared of falling. And again, I think it's really important to know that they might not have shared that or have the capacity to share that, but often the fear is there, and it is real. There's worry about losing balance. They might have seen other peers fall, whether they're within any, involved in the community with other young people with neuromuscular conditions or not, and fear about not being able to get back up, or what's going to happen if I do fall, who's going to need to help me, will other kids see if they're at school, things such as that. And it does have an impact on behaviour beyond what is just seen as those being naughty behaviours or those defiant behaviours, and toileting and using the bathroom is a big one. So we might have that resistance with going to the toilet because they might be scared of falling on and off of it, particularly if they are still independently using it. Drinking less water to avoid needing the toilet and feeling dehydrated.
Toileting is always an interesting one, because I would say the majority of the kids that we work with do not go to the toilet at school for either urination or bowel movements. And then in fact, that kind of rolls over into home, because then I just had one of the boys this week, and he said, I haven't been for a poo all week. And so I had to set a bit of a routine on, okay, well, just for 3 days, I want you to just follow this routine, sit on the toilet, we'll take some medicine, we see if we can't clear it out, and then set a routine to continue with that. Because toileting, both urination and, a lot of these kids have difficulty with constipation too, which then kind of flows out onto school, because if you've got constipation and you might do a bit of a pop off or a bit of a fart, and then if you've got constipation, that's going to put a skid in your bottoms. And then for the kids to be at school with skinny pants isn't very nice, because they might smell, and then mum might think he's not wiping himself properly because he's got skids, and so it's a complex area. And it's actually, we do a lot of poo study. It's one of my favorite things to do, a bit of poo study. But it's actually looking, again, that's another fear for them. I'm going to school, I then do a fart, because what if I smell of poo, and then I'm going to get home, I'm going to maybe I get into trouble because I haven't wiped myself. So, there's a lot around toilets. The other thing at school, toilets are often wet. People don't wash their hands properly. We went into a toilet this week and it had an apple on the floor, a crunched up apple, and there was some toilet roll and water, and the kid walked past and he said, I don't think I'm going to use these toilets. And I was, fair. Which ones are we going to use? We're going to use these other toilets. Went to use the other toilets. The door was too heavy. Couldn't pull the door open. Got inside. And after about 5 minutes, we heard, knock, 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 knock. Can you let me out? Then we have to open the door and let him back out again. So, I think all these considerations. The other thing we've had happen is that we've had some of our older boys in high school where we've left them going off to the loo by themselves, and they've ended up between the toilet and the wall, and they haven't been able to get up, and they haven't been able to press an emergency button, and they've sat in between the toilet and the wall until someone has noticed that they're in the bathroom stuck. And then we've had to call an ambulance to get them out, because the staff can't lift them up because they're wedged in. So having risk plans in place, or plans in place around toileting and falls, is really important to have that with your physio, your OT and school. And I think that also it's good to have someone within your team talking to the child about, what is your plan B? It's okay, you can go to the toilet by yourself, but what is your plan B if you fall? Who's going to know that you're there?
I think it just starts with a conversation too. Like, again, it's the earlier you can start these conversations with the team, the better. And I do just want to note too, on toileting, one of the other things, doing a lot of that on the floor work around behaviour. What we do tend to see, often the kids have quite poor interoception, and as that fear starts to increase, it's really hard to navigate the difference between, well, what is a gastrointestinal difficulty and what is that feeling of worry or anxiety or fear, and knowing how to respond to that. And it can be really tricky, and it's hard for everybody because they do often feel the same way, and it can be quite complex overplay with them. So I guess it's toileting, getting onto that really early is really beneficial because it can definitely.
I would love to do more research on constipation in boys with DMD because I don't see any rhythm to it. You know, kids can be eating the right things, drinking the right things, moving around and still get constipation. And then, you know, other kids might be eating food that not vegetables, not fruit, and poop freely. So it would be interesting, I think, to see more research around that. Perhaps I could do a PhD in food. I don't know.
I think looking at how do the boys and the individuals with DMD feel. So when we're talking about what that progression is, again, it's not just about the muscles or the equipment or the steroids, but we're talking about how all of these changes actually feel for them. So we see that fear, that worry. Then what we also start to see is the fatigue and the lack of motivation, which we'll come to in a moment. And again, just that fact, because we do really like to emphasize that the steroids are often, they're not creating the problems. They might increase the fatigue or irritability or the dysregulation, but it's that magnification of what's already there or, you know, likely to be there. And it can make coping harder, but, you know, it's not the sole cause.
You really see kids as well as they get a bit older and there's a ramp and stairs and they'll look at the ramp and they'll look at the stairs and you might give them an option, you know, which way we're going to go. And the ramp seems like such a long way to walk, but the stairs are such a steep increase that how are they going to get to the top of them? And often they'll take the stairs and often you stood behind them, just hoping that they're not going to fall back on you as they go up. But, you know, I think you can actually start to see that fear and fatigue when, you know, when they're looking at distances to travel.
Fatigue is obviously a huge one, but it isn't just physical, as it never is in Duchenne. So we do see it show up in three ways, and we like to assess these three ways so we actually can, you know, have the evidence and the data, and we would like to do it with the individual themselves where we can, because hearing from them and helping them understand, you know, it's not just your muscles that are tired, but we do have the physical fatigue. Muscles do tire more easily, and everyday tasks do take more effort, but there's also cognitive fatigue, so concentration, problem solving, it takes more energy. I think a lot of the times, for looking at the school context, even some of the brightest boys with DMD who do really well and they push really, really hard to keep up, by the end of the day, or let's say approach the end of primary school, they might be struggling more than they once were. And then when they get home, it's even more so. It's totally different. You know, a 5-minute task can feel a bit like World War III when you're trying to ask them to do it. Learning and decision making can be overwhelming as well. So just simple decisions can be really tricky. You know, what do they want to have for dinner? Things like that. It can be really hard.
I think when that cognitive fatigue kicks in as well, again, this is where we start to really see that kind of rigidity and that kind of pushback and
things being in control too. Like things maybe like it has to be, you know, no, I'll do it. It really sort of intolerant of letting people help, even if it's a small mistake, and seeking that success as well. I think, because I guess in my context, doing a lot of that sort of one-to-one support with them, if we're doing low level, low demand, high interest games, sometimes little mistakes can occur and it can be a big, you know, we need to address it. So it's a real, you know, it has a real tangible impact.
Yeah. Later schools and teachers, leadership, and to support staff too, but it's putting it into perspective a little bit. Like if you're cognitively fatigued, like you think about the end of a year or the end of a day, and you've got a gazillion things that you need to do. You might need to get to those emails, you know, you've cooked tea, you're running around, you've got 100 things to do, and you start to park things. You park the things that are less of interest to you because they're harder to do. And these kids are no different. Like if they're cognitively fatigued, you know, they might say, well, what do I have to do Japanese for? You know, it's not important to me. What am I going to get out of this? So, and that can be perceived as rude or rigid, or however, as adults, we do exactly the same thing. You know, it's like, well, I can come, I'll do those emails tomorrow, and maybe I'll just pour a glass of wine and do what I want to do, and I'll check those, I'll do them tomorrow. And for them, it's the same thing. Maybe I just go play on my iPad because you know what? I can just have some downtime on my iPad.
I think what's worth noting too, again, I'm looking from more of a school lens here, but it doesn't always make sense to us too. We might think, okay, well, if that's the case, they're not going to want to do the tasks that are physically demanding, but almost always, if it's a lesson, you ask them what's their favorite lesson, it's PE. Every other lesson might be, I don't want to do that. It's not what I want to do, but PE, even if it is tiring, it might be meaningful to them. So I guess it's worth thinking often when they are parking those things, it doesn't always mean they're going to be parking the things that are physically harder. It's the things that aren't meaningful to them, as well as the things that are hard. But yeah, I think that's just really important to consider, because I think teachers look at it and go, well, why would, they won't do this, but they'll still push and push and push for PE.
Or they'll do it one day and won't do it the next. And it's like, well, it was of interest that day. It's not of interest this day.
Yeah. And sleep and rest, it's, sleep will start to be disrupted, discomfort as they get older, breathing, and maybe the introduction of equipment like BiPAPs or anxiety around sleep. And even with enough sleep or enough hours of sleep, rest might not feel refreshing. They might not wake up feeling refreshed. They'll often wake up feeling fatigued.
And again, for the kids fear, I know heaps of our kids sleeping with mum. Or mum sleeping on the floor in there, because the kids just are so fearful they are unable to sleep alone in a room. And again, this is stuff that we have to address a lot. The other thing is that we assume that if we're fatigued, we sleep well. But if we're fatigued, we sleep less because our brains are just not switching off. So again, this is something, again, we measure. So we do use assessment for these things. So we really understand why things are occurring and how we can manage it.
I guess then we like to sort of reflect on those areas and the link between fatigue, motivation, and anxiety, but also fear. So prior to that plateau stage, motivation in those with DMD, it naturally increases and decreases for everybody. They might have that anxiety or fear slowly start to rise as they're feeling different from others. Maybe they're starting to fall a little bit more. You might still see some growth in those really early years and in early childhood, and fatigue might not be as noticeable. But that's when we get to that plateau stage, and assessments like the North Star will start to show the decline in physical ability. And so then after that, what we start to see is physical ability decline, and it's more visible. Fatigue starts to increase, and it's both physically, cognitively, and in sleep. That anxiety and fear is going to increase further. You'll see a lot of questions, what's happening, and it might not be something that's talked about, or it might be talked about a lot in a hospital setting, and they hear little snippets, but then not talked about again. And they're often sort of left wondering, well, what they're experiencing it, so they will have the questions. And motivation can continue to decrease, even if it's something of interest and meaning.
Motivated to do it, maybe no.
So there's all these sort of implicit demands around it. They've got to get up, they've got to get out of bed, they've got to get dressed, they've got to get there. It's even things that they might have loved maybe yesterday, they might be reluctant to on another day.
And this is where we see the motivation to go to school get really affected too.
And that's where we're looking at the window of tolerance. So that that window is a zone where a person can manage stress and stay regulated and feel in control. And when we're in that window, we can think clearly. We're able to learn and connect and adapt and respond flexibly. So to an expectation, and it might be for a young person an expectation to listen to the teacher talk for 5 minutes, and so within their window, if they're in that optimal state and they're traveling well, they can deal with those demands and they can deal with the stresses and they can meet those expectations. What we'll then see is something might trigger dysregulation and things will go out of our window, and that's when we react. So if you're pushed out of that window, you're moving into that stress response, so that fight, flight, freeze. You might be in that hyperarousal, which is sort of overactivated, on edge, or hypoarousal, which is the flat, shut down, low energy, and it's the brain's.
You see this in
kids. So, and this is the brain's way of reacting when things are tricky. And for us, or for other people, for other individuals who may not have DMD, often we will have those tools to regulate. That will occur, and we'll know, okay, we need to take a break or have a wine after a long day, like Michelle said, or whatever it may be.
I think as well, just thinking about, can you just go back on hypo, like the withdrawal? So when you think about hypoarousal, often these kids get missed. They'll be at school, they're quiet, they're not loud in a classroom, and we see them withdraw and withdraw and withdraw. And then we see the other kids that are out there swearing and sticking their fingers up and carrying on and taking their clothes off, do whatever they're doing to upset the classroom. These are the kids that get the attention. These are the kids that get the help. So it's really important that even if a child's quiet, that we're still acknowledging that it is just as significant as hyperarousal. So both hypo and hyperarousal are equally as problematic.
And I think when we're looking at, children or young people with Duchenne, it can happen more quickly and more often. If we're thinking about what will have that impact and create what we'd call that reduced optimal window, there's physical fatigue, there's cognitive fatigue, disrupted sleep, that we might be experiencing pain or discomfort, busy or demanding days. There is also a sort of neurobiological basis to this, which we cover in the second one, around that impact of dystrophin in the brain, which I think is really important to consider here. But we obviously will go through that in the second webinar in detail. But they have that reduced optimal window almost all the time. So less stress is needed to push them outside of that window. So we almost see them in that heightened state, or, and I say heightened, that could be that more withdrawn state, but almost always. So it can look like emotional reactions that are bigger or quicker than expected. You might sort of ask them to pick something up or, go do something, and you get snapped at straight away, or refusal or withdrawal, even if the task was manageable before. Tearfulness, shutdown, increased irritability, difficulty starting tasks or making decisions. And I think making decisions can be a really big one, because it can be simple decisions, needing more time or space. These responses, I guess, are signals that capacity has been exceeded, not that they're being difficult or non-compliant.
And I think as well, this is also where we start to get people, talking about comorbidities and talking about, behaviours perhaps fitting into another box or another diagnosis, which is also scary. So I think, and again, we go into more detail about the symptoms or the effects on the brain and how that looks with comorbidity.
There's a real complex, I think, overlap with sort of window of tolerance, the impact of disrupted dystrophin on the brain and cognition, and then the physical progression of the disability. And they have a really sort of interesting overlap, which we will look into in a lot of detail in the next one, which again is, I think, more of that, well, why are we seeing it? What does it, what causes it? And really unpacking why it's not just a choice, and it's actually reasons behind this, which I think is really important when we're looking at, well, what do we need to do? What can we do? We need to know these things. So I guess, just to sort of summarize what we do commonly see, and I guess for any of the parents or families in here, is probably worth thinking, well, which of these, if any, do you see? Because you're more than likely not alone with it. But those refusals, avoidance, that loss of motivation. I don't know how, we've gone through these quite a lot. So is there anything you want to?
I do think that initially, the kids, one of the things that we come across is refusal a lot. And I mean, when we say refusal, we just kind of mean that, no, I don't want to do that. No, I don't want to go there. No. And I think this is a common thing that we're often not battling with the kids, but we're often needing to talk to the kids about it. And we're often helping them do kind of mini risk assessments, and also kind of paving out pathways so things are predictable and they know where they're heading. And I think one of the real difficulties I find is this medical model where we see lots of big conversations happening around these little kids, and when they've got all this going on and their cognition's affected and they're fatigued, and you go into a hospital appointment and they talk about 2 and 2, and the kids go home, they put 2 and 2 together and they come up with 22 when they should have come up with 4, and all this stuff goes around their head. There's fear. So I think it's really important to make things clear to the kids and help them with risk assessments, because they're not silly. They can actually, with the right guidance, have a fair bit of autonomy in their choices.
And I think that's why it's important to have a team who sort of are working with like a multi or transdisciplinary approach. And we really go into that in the fourth webinar as to how that can be put together. But that's where, we don't work in a silo. We will work with the physio, the OT, the speech pathologist, whoever it may be, support staff, because if you've got a team approach and you're coordinated and you're working towards that common goal of making things transparent, but addressing the fear, and also they can support the family with the grief as well, because it's equally as important from our end. While we do a lot of like one-to-one work with the individuals, you still have to work with the families because they're on the journey as well. So I think it's really, you can have a team around them that, if they understand DMD and the community well, we can see a lot of autonomy and success and reduced behaviour.
You only know what you know as well. So, if you've got a wider team with more experience, or there's, information that you can tap into, then, your team can be very much upskilled and informed around a lot of this stuff. I think that one of the things for me is why I feel like it's so important in these younger years now is because of the longevity. I was just in Queensland last week visiting a very good friend of mine, and her son is married and in his 40s and lives alone. Lives with his wife, actually. He married her when he was 35. And, one of the conversations we always have is that we've got to get these kids ready for adulthood, because adulthood comes, and so I think they need to be ready. Yeah, so this year, we've got kids that are 20 that just access community-based activities. They have a bit of a micro business going on. Then we have another side where Tom's just basically helped one of the kids at uni, 6 hours at uni. Yeah.
So, and I think it's really important to note here too, like success can look different for every individual, and it's not always just about did they get their year 12 certificate, says here in SA, or did they go to uni. It's also, I think, for that, particularly that 20-year-old too, their week is just as meaningful for them as going to uni is for the other. So success is real there.
And success is really driven by parents physically, I think, more so than perhaps success for the kids is more around being a part of things, being successful, having peer support, not feeling alone.
I think what we do see is they get to a point with the progression and with their age where they worry less and think less about their own physical capacity, and they do think more about what's meaningful to them. And I think for families, they often still hold on to that feeling around where they're at with their physicality and their independence. So it's working alongside all people. Yeah. I guess if we're just sort of summarizing why it can be confusing and challenging, a lot of behaviors at times, they don't always match what we might expect or what we know of behavior for professionals who are working there, but also for parents, it might not make sense. And that's quite common. So you might see them refuse something that they enjoy. Doesn't mean they're being lazy or choosing not to. Saying no, if you haven't actually noticed anything noticeable change, it might just kind of come out of nowhere. They're not necessarily it's not as if they don't care or they're choosing to be rude. Becoming upset if a task seems small, even if familiar. It's not a choice. I think it's a communication. So if we're thinking of it as communication, it could be a range of things. It might be fatigue to reduce capacity, even for preferred activities. Cognitive load's already high and we've seen an increase in fear. They might be outside of that window of tolerance before the task has even begun. And I think when we see those behaviors, they're not choices or character traits. It is, as it says, communication. So it's telling us something about fatigue, fear, and capacity. So it helps us start to think differently about, well, how do we respond? And that's when we get into those. The next few webinars, the second will be, well, what is the sort of biological underpinnings? And then the third will be the how do we respond?
I think as well sometimes with that kind of pushback, like I'm thinking about other kids with neuromuscular conditions that we work with, and sometimes they actually just don't want to put on their parents, like getting ready, putting yourself in a position where you have to rely on others to help you and support you with that, and then getting out into the community to do something. Even some of our younger ones, and I'm thinking about one of our younger girls that we're working with at the moment, and she said to me, it just takes so long to get ready, and I don't want my mum to have to go through that every morning. And I said, well, the choices are, if you don't get ready and you don't go out, what happens? And She said, you just stay at home. And I said, yeah. And when you're staying at home, you're not connecting, you're not finding the things that you love doing, not getting your nails done and going shopping and doing all those things that young girls like to do. So I think it's important sometimes to also kind of consider that sometimes the kids are actually protecting their mums. And they're very connected to mums. If mum could do everything all the time, every minute of the day, they would be very happy with that. But this is a really long journey. And you don't want to get to the point at this age when they're 20 and you're hitting a wall and you feel like you can't keep going. There needs to be things in place so that your young adult child can be a young adult. This week, Jack went off to a market with me and his dad, and we got home and he said to me, I think I might go with my carers next week or next time it's on. And I said, okay, that's fine. He said, pretty much like, no offence, taken. Off you go. That's not a problem at all. But, I think that when you're younger, it's really hard to imagine your adult child going off and doing things without you. But it's a nice feeling that they can do that.
So yeah, I think that wraps up this first one. And I understand for many of the families or people in here, it might be a lot of things you already knew, but it's really, I guess, important around just sort of reflecting on, well, what do we see before we look at the why and the deeper why, which is, well, how does this disability actually impact us beyond the physical in terms of the dystrophin in the brain? And because that does change coping and behavior. And then that's when we'll move into that third one, which is around meeting need and those more tangible, practical, well, okay, well, how do we respond here? Before I think finishing on that, creating a team around the child and having a team that can understand all of these elements and put things in place that.
And I guess just to sort of clarify that in South Australia, if we don't work directly with the kids, we are involved with a number of them, and sometimes we're just in the background, sometimes we just get called upon when needed, but a lot of what we talk about comes from the learnings that we've had from working with the kids, and then we're placing that with the latest research that Duchenne Australia will share with us, and when they're off on their journeys, finding papers for us and working out what's happening. So I think that it's important that, when we talk, we talk from the point of view that, we're very lucky that we have a good cohort of kids with DMD and
dystrophinopathy and other neuromuscular conditions. Often if we do any group-based or community things, we have a lot more families and individuals join in.
And also that we really value the importance of working and connecting with other teams so that everybody's learning, because that's important too.
There is a getting in touch link for our site for any families or anyone. There's also a more formal referral form, but I'm sure Kathy will happily share if need be. Over the next few weeks, the website may look different, our flag, but it is still functional and usable if anyone does want to get in touch. And I think, I've seen there's a couple questions in the Q&A chat.
Tom's looking at me when he talks about the website because I'm not allowed to touch it or the social media, apparently.
I'm handing it over now, so it will look better than it does because I am not a web designer.
Let's have a look. Let's have a little look.
Thank you. Kathy, is it worth me stop sharing?
Yeah, I'll just jump in. I think it's so. Thank you so much, you two. Obviously, I've heard you guys speak a couple of times, and every time I just love it. And I think you really set the fundamentals for our first webinar, and there's heaps to build on. I think one of the most important things here is, for us and our families is, I think for a lot of us is the validation, of this is not, it is our son, but the behavior is because of so many things. And, these kids are coming to, they're dealing with so much. And I think once there's more understanding and more sensitivity around, what they're going through, I think the more people in their circles that understand what they're going through, the more space people give and people are a bit more sensitive. So I think that's the most important, important thing that I say to parents is these kids are on the daily, have like, they're doing it tough, but they're strong little things. And so their behavior, that's the way that they reflect their fatigue and that. So
I think it's human nature as well, that there's an underlying assumption that things will always get better. And so a measure is very different in these kids because things do get better, but in a different way. And that's where it's tricky that, yes, physically things don't get better, but the way we live life and the purpose, success, the importance of life increases. And so that's how you get your balance. But for schools and people generally, a lot of people find it difficult to think like this, or to think that the kids think like this, because it's our nature to make things better, to increase things, and sometimes it needs to be increased in a different way.
And we rely a lot on assessment and are driven by a lot of sort of measures in the way we assess, but often it's not a measure of success. It's more a measure of sort of informing us around, okay, well, this is where they're at, well, what will success look like for them, and what will autonomy look like?
How can we build a new pathway so that it works for everyone? It looks like we've got a couple of questions.
Yeah,
we do. So the first one is, when waking up in the morning, so this is obviously around sleep, can they have good days where they are well rested, or will they always be fatigued?
So I think that there's always a general element of fatigue. However, I think that it's about using your team around making sure that you're maximising the golden standards of care. So I can remember Jack was 10 when he went on a BiPAP machine, and I thought, oh, he must be the worst kid in the world. He's 10, he's on a BiPAP machine. This is awful. Am I going to lose him? And he went on this BiPAP machine. He's been on it for 10 years. Best thing we ever did, because when he woke up, although he had an element of fatigue, he wasn't cognitively fatigued. He had a good amount of sleep. As he's got older, the use of things like cough assist machines, and again, horrifying that you would have to use those things. But this actually has given Jack quality of life. So yes, he wakes up tired, and I'm not going to lie, there's some days when he says to me, Mum, I don't know if I can keep doing this. But most days he will wake up, and I'm going to lead on to the next question on how often do Jack's carers step up into to support me as a parent. So Jack pretty much every day has care Monday to Friday from 7:30 till around 6:30. And how they help me. So today one of the carers cancelled, and another carer rang someone who's one in Jack's team and said, Ben's cancelled, Keith, can you come? And Keith said, yep. Now that carer didn't have to do that. They're an independent worker. But what they've done is they've made sure that someone else is going to come in and do that afternoon shift. And I've remained at work. He knew that I couldn't get home tonight because I was doing this. And so he stepped up and he's done that. But carers listen. And I think my friend Michael Squires made a really nice comment the other day around carers. We were looking at this in the chat, and he was saying that with the right team, these people become part of your family. They walk in and out of our house. They're part of the furniture, but they're people that we trust and we connect with. And like my story before, Jack is actually at a point now where he would rather be with those guys doing whatever he's doing than with me, because I'm probably old and boring. So, but we've had to work at that. We've had to create that. It didn't just happen. Jack would have stayed at home with me every day, hands down. He would love it. There was one time when he got on my Facebook and he'd written some swear words about my work, which was horrifying. But he's got to learn that he's an adult.
Yeah, and I think from a capacity building standpoint, if there's any other providers in here, whether it's an OT or physio, they're also great to work with. If I think Jack's team in particular, because he has quite a consistent team, and he does have a lot of time with them away from mum and dad, working with them to actually set check up for success. And therapy, I guess, doesn't always necessarily look like that traditional every 2 weeks catching up in a clinic, but setting things up. And I won't go into too much details around what that looks like in the way of services, but it can be useful to link in with support staff and upskill them to put in place programs so you can kind of pull yourself out of a job, and you don't need to be there every 2 weeks doing skill building, because they're doing it in the natural environment where they're actually going to use the skills and not in a small room where they're not. So
really important to have well-trained staff and around the behaviour stuff.
Yeah.
What's this one here? I've got another one. Is there any benefits?
So if there's any benefits around something like a Whoop strap or wearable that monitors sleep, is this something that you've seen in other Duchenne boys?
So I guess you would get a sleep study in terms of monitoring sleep. I know that some kids have watches. I know that Claire Bailey, who's I don't know what her position is that with you guys.
Co-founder.
Yeah. So, there was a point where she'd done a lot of research. They did a research program on wearing a watch so that could monitor sleep. But I think if there's worries about sleep, then I would be consulting with your medical teams and looking at sleep patterns, sleep studies, which I don't know why they call them sleep studies, because you only ever get about 2 hours sleep.
And can I say on that too, again, it's I think I don't want to keep plugging the future webinars, but the fourth one will be really useful for that, because sleep studies aren't as simple as just booking in and going. We do a lot of work
prepping the kids out,
but the families and the kids, and sometimes it's just the parents doing the work. But in terms of those we do support face to face, it's never as easy as we've got a sleep study. Are you ready yet? Let's go. There's a lot of fear. There's a lot of worry. Making it really clear and transparent, using social stories or real visual stories around, well, what does it look like at the hospital? What to expect? I think it's not necessarily related to a sleep study, but we have stories around where they've heard or they think a hospital visit's going to look a certain way, or a Canada's going in a certain way, and they've not been able to share that. Once we've unpacked it, we've been able to identify, okay, this was a specific worry. Let's make it really transparent. So that's where, again, we see those escalating behaviours leading up to appointments, leading up to sleep studies. So having a team to work on that is useful.
It's very hard for a parent to tell a child what it's going to look like when you've not been there yourself. So, to say, oh, we're going to have a bone infusion. Well, the hospital don't tell you what that's going to look like before you get there. So you're looking after this little bundle of joy, and they're bouncing off the walls because they're not really sure what the hospital's going to look like, and you can't reassure them because you don't know what it's going to look like either. So it's really important for us that there's information shared so that the kids have some idea of what that's going to look like.
Yeah, and I think with these kids as well, they're a lot smarter than they look. They can read us. They can read us. So you might say, oh, mummy's fine, and I'm not. It's all going to be fine. But if you're not fine, I think that they're very good at picking that up. So even though they don't say it, but yeah, they're clever little things.
Being honest about it too, like if you do have those worries and not sort of, because like you say, Kathy, they often can read through it. And I'm not a parent, so I'm hesitant to speak too much here. But from what I've seen, I think even if you do try to downplay it, they might read through like a book, and it doesn't. I think sometimes just being honest with them, like, no, you're right. I don't know what it looks like. Let's find out. Let's have a look. And do it with them, and
And it's not oversaturated. You don't have to give them too much information. I think one of the really scary things is them going onto Google and Googling things. And we always say that if you give them enough information within reason, they don't feel the need to go and Google, because you're answering the questions, you're fulfilling their need. And often we say to people, if your kids ask you a question and you're unsure, tell us, we'll answer it for them. We'll do it factually, and we'll make sure that we're not oversaturating them by information that might scare them. That's the last thing we want to do, scare kids. We want to calm them, reassure them. Yeah.
So if there's no other questions, I think the only one is a copy of recording tonight. Yes, this session has been recorded, and we will be posting it. TBC where. I will get back to you. But look, I feel like we could sit and chat all night. I think next time I will try and work out this webinar series so I can see the lovely faces of our parents and therapists and carers and professionals and family members that might be on the call, because I think there would have been a lot of nodding tonight. So, guys,
we're very excited about the next ones. You know, it's getting into the things that we love. It is, you know, the brain and the workings and the so it's something we're very passionate about. So we hope to see you all at the second one too.
And which one was it, Thomas, that you said it would be best for to get your teams involved? So number 4.
Yeah. So if you have, you know, allied health providers or DEs or DEs and allied health providers, OTs, speeches, physios, support staff, anyone, it's probably a good one where it's, I guess, more around, well, what does for a young person with DMD, what does a good quality of care team look like around them, and ways to establish that as well.
Yeah.
So I think that's probably the most relevant to that.
Awesome. All right. Well, again, I just would like to thank you so much for your time. You guys did amazingly and really set the foundations for the rest of the webinars. And we'll see everyone in 2 weeks. And there will be a survey that goes out post this. And if you guys will could fill it in, that would be wonderful, just to help shape future webinars. So thank you, everyone. Oh, hang on, I've got another one. Thank you. Oh, James. We'll chat. Let's chat, James. Okay, well, thank you, everyone. Thank you very much. Sweet dreams to everyone. It's a bit late, but we'll see you next time.
For your time.
Bye.
Bye-bye.